Now in general pharmacology, the next topic that we are going to see is pharmacodynamics. Okay, now pharmacodynamics में सबसे पहला जो concept आता है, basically you all know that pharmacodynamics is the study of effect of drug on body, right? Now the drugs, they act either by physical mechanisms, that is osmotic diuretics का action होता है ये, या they act by chemical mechanism, that is like antacids, or they can act by enzymes, by stimulation, that is enzyme induction or enzyme inhibition, right? Now let's study about enzyme inhibition. एक इसमें ग्राफ था जो मैं आपको कराना भी चाहती थी, तो इस तरीके से ग्राफ आपकी बुक्स में भी होगा, that ये this is substrate concentration and this is reaction velocity, right? Now this is the graph shown by a normal drug. Okay, this is the graph by enzyme induction, and this is when there is enzyme stimulation. Okay, and this is the graph when there is competitive inhibition, and this is the graph when there is non-competitive inhibition. Okay, so this is the graph system that you must have seen. Now there are some important terms here. Say this is half Vmax, okay, and this is Km. So understand what is Km. Km is the rate constant of reaction. Okay, Km is the substrate concentration at which half Vmax is achieved, right? So this definition becomes very important. What is Km and what is the exactly what do you understand by Km? Then another thing is Vmax. Vmax is the maximum reaction velocity. Okay, so here as you can see that I have written this is half Vmax. Vmax is total Vmax is here. Okay. Now as the drug is in the enzyme is induced and stimulated, you will see that there is basically a new Vmax is achieved, a new reaction velocity. This is called as Vmax of stimulation, right? Then this once you go down, then here you will say that half Vmax of inhibition. Here you will see this is Km of stimulation, right? And this is Km of inhibition, right? Like this. So what we understand by stimulation and induction. Stimulation, when enzyme is stimulated, how do I write it? Okay, stimulation and induction. Stimulation when the enzyme, the affinity for the substrate is increased, and here you will see that Km is reduced. Okay, so when there is a stimulation, then the enzyme attaches to the substrate with more affinity, and hence Km, that means the concentration at which half maximal velocity is achieved is reduced. That means Km is achieved faster, right? Km is reduced, sorry. So these are the two things which you have to see: stimulation and induction. Stimulation when affinity is increased and Km is reduced. So this is stimulation. What is induction? Induction means there is synthesis of more enzyme. Okay, here Km does not change. Here there is no stimulation. There is no stimulation of the enzyme. It's just that the number of enzyme molecules is increased. So this is basically induction. And as we know, many microsomal enzymes are induced. So this is the induction. And induction, you can see again the graph has moved upwards, right? Next, we come to the inhibition part. Now inhibition is something very important. Inhibition part में हम देखेंगे कि we have two types of inhibitions. One is competitive and one is non-competitive. Okay. Now competitive inhibition, as you can see that the reaction with the or I'll say to achieve the same half maximal velocity, more Km is required. So Km is increased and Vmax remains unchanged. Okay. So in competitive inhibition, please understand this. इसके ऊपर questions आते हैं. Competitive inhibition में as the graph has fallen down, and so here in competitive inhibition there is increase in Km and Vmax is unchanged. What does it mean? It means that for same half max velocity, now more substrate concentration is required, right? So this is competitive inhibition. So competitive inhibition में Km is increased, Vmax remains unchanged. Competitive है, so what will happen is when you increase the substrate concentration, it will replace the antagonist, it will remove the antagonist and again attach to the receptor, and that will mean that if you add more substrate concentration, you will be able to achieve the same half maximal velocity, right? Now this is competitive equilibrium types. ठीक है, कॉम्पिटेटिव में भी दो तरीके के होते हैं, इक्विलिब्रियम. अब देखते हैं कॉम्पिटेटिव नॉन इक्विलिब्रियम. competitive non-equilibrium can also occur. Here now basically the drug reacts with the same catalytic site but forms strong covalent bonds or has very high affinity for the enzyme, so that normal substrate is not able to displace the inhibitor. So here basically non-equilibrium type means they form very strong covalent bonds which cannot be displaced. Okay, so this is non-equilibrium type. Now here what happens, here Km is definitely increased and Vmax is reduced, right? मतलब substrate concentration तो बढ़ेगा ही बढ़ेगा और Vmax जो है वो भी कम हो जाएगा, Vmax भी कम होता जा रहा है, and so that means the reaction velocity becomes very less and the Km is increased very much. For example, here you know OPCs, organophosphate, they react covalently, okay, with the asterotic site of the enzyme cholinesterase. Then another example is methotrexate. It reacts with the enzyme dihydrofolate reductase with 50,000 times more affinity. Okay, so here remember in competitive non-equilibrium, this was equilibrium, Km is increased and Vmax is reduced, right? Now the third type of inhibition we have to see, that is non-competitive inhibition. Okay, now non-competitive inhibition क्या होता है? Non-competitive inhibition means that the inhibitor or the antagonist reacts with an adjacent site. It does not react with the normal site of the catalytic site, but it reacts with an adjacent site and not the catalytic site, right? So in it basically by attaching to that adjacent site, it alters the enzyme and loses its action. Now can you give me an example of this type of non-competitive enzyme inhibitors? Yes, we have a lot, but before that let's see. Now in this what happens, Km remains unchanged and Vmax is reduced. What does that mean? It means that Vmax जो होती है, जो रिएक्शन वेलोसिटी है वो पूरी तरीके से रिड्यूस हो जाती है, मतलब रिएक्शन बहुत स्लो चलता है, and Km remains unchanged. Km मतलब the substrate concentration at which half maximum velocity is attained, it remains unchanged. Km को चेंज करने से भी कोई फर्क नहीं होता है इसमें. It doesn't matter. It remain मतलब आप कितना भी Km बदलोगे, लेकिन because the inhibitor is attaching to the adjacent site, so it will not increasing the substrate concentration will not bring any change. And here Vmax will be reduced. The reaction velocity is reduced too much. I'll give you some examples like omeprazole inhibits hydrogen potassium ATPase enzyme. Theophylline inhibits which one? Phosphodiesterase 4. Then we have digoxin, which inhibits sodium potassium ATPase. Then disulfiram, which inhibits the enzyme aldehyde dehydrogenase. Right? There are many examples like aspirin, which inhibits COX, it causes irreversible inhibition. Then acetazolamide, which inhibits carbonic anhydrase, right? So these are the various examples of non-competitive inhibitors. Competitive inhibitors के नाम में I will discuss that also. Now coming to, let's see the competitive inhibitors also. Competitive inhibitors. Now what are the competitive inhibitors? We have cholinesterase is the enzyme, the substrate is acetylcholine, and the inhibitor is physostigmine, neostigmine, which are cholinesterase inhibitors. Then MAO-A enzyme, the substrate is catecholamine, noradrenaline, and the inhibitor is moclobemide. Okay. Then dopa decarboxylase enzyme, the substrate is dopamine, and the drug is levodopa. Sorry, the drug is carbidopa. Okay. The substrate is levodopa here. It acts on levodopa. Then xanthine oxidase. What does it act upon? It acts upon hypoxanthine, and the drug used is allopurinol, right? Angiotensin converting enzyme acts upon angiotensin 1, and the drug here is ACE inhibitor. 5-alpha reductase is the enzyme. The substrate is testosterone, and the drug is finasteride, which is 5-alpha reductase inhibitor. Aromatase, the substrate is testosterone, and the drug which is aromatase inhibitor is letrozole. Then we have folate synthase. The substrate is PABA, and the drug which acts on it is sulfadiazine. Okay, so these are the competitive and non-competitive inhibitors that we have seen. Now the next part. What are the other mechanisms by which drugs bring about their action? So this is ion channel. They bring about their actions through ion channel, and there are how many types of ion channels? There are ligand gated. There are protein channels, and then there are voltage gated and mechanical or stretch sensitive. Okay, these are the various types of channels. So ion channels basically क्या होते हैं? They help in the transmembrane signaling and they help in the regulate the transfer of ions from inside to outside, and then they bring about those actions. Now ion channels, ligand gated ion channel मतलब some molecule has to attach here. Okay, G protein coupled channels होती हैं in which G proteins they are the ones which activate them. Then voltage gated में basically potential action potential comes and activates them. Stretch sensitive mechanoreceptors होते हैं जैसे, so they get sensitized by the stretch, by the increased blood pressure, increased volume, like that. Now let us see some examples. So examples इसमें हैं जैसे, अब ये एग्जाम्पल्स जो मैं आपको बता रही हूँ ना, आपको लगेगा मैडम क्या एग्जाम्पल बताने लगी है. एग्जाम्पल इसलिए बता रही हूँ क्योंकि इस पर भी क्वेश्चंस पूछते हैं. जैसे एम्यूडेरॉन एक्ट्स ऑन विच टाइप ऑफ कैल्शियम पोटेशियम चैनल. सो एम्यूडेरॉन डिलेड रेक्टिफायर पोटेशियम चैनल को ब्लॉक करता है. आई राइट इट हियर. एम्यूडेरॉन ब्लॉक्स डिलेड रेक्टिफायर पोटेशियम चैनल. ओके, नेक्स्ट क्विनिडीन किसको ब्लॉक करता है? आप कहोगे सोडियम आयन चैनल्स को करता है. सो यस, इट ब्लॉक्स द मायोकार्डियल, इट एक्ट्स ऑन सोडियम आयन चैनल्स. निफिडिपिन किस पे एक्ट करता है? निफिडिपिन ठीक है, सीसीबी है, सो इट ब्लॉक्स द कैल्शियम आयन चैनल्स. बट एल टाइप वोल्टेज गेटेड कैल्शियम चैनल्स. ठीक है, ये याद रखना बहुत जरूरी है. कौन? निकोरेंडल. निकोरेंडल इट ओपन्स ATP sensitive potassium channel, right? Then we have sulfonyl ureas. Sulfonyl ureas inhibit ATP sensitive potassium channels. Then we have amiloride. Amiloride inhibits renal sodium channel. Okay, that is renal epithelial sodium channel. Then we have phenytoin. So phenytoin prolongs the inactivated state of voltage sensitive sodium ion channel. So these are various ion channels which basically play a role in the enzymatic reactions. So this we had discussed was ion channels, right? Now the next that we are going to discuss is the transporters. Now why are transporters important? Transporters, right? Now transporters क्या होते हैं? Basically several substances they are transported. So substrates are transported across the membranes by binding to specific transporters, right? So substrates are transported across the membranes by binding to specific transporters in which either they have a diffusion, facilitated diffusion in the direction of concentration gradient, or they pump the metabolite against the concentration gradient, right? Now I'll give you some examples of these transporters. For example, desipramine and cocaine, they both block the neuronal uptake of noradrenaline by noradrenaline transporter. So this is the mechanism of action of cocaine. It blocks the uptake of noradrenaline by interacting with the norepinephrine transporter. Then we have other antidepressants like fluoxetine and SSRI. They also block the neuronal uptake of 5-HT and serotonin transporter. Then other drugs are there like amphetamine. Amphetamines क्या करते हैं? They block the dopamine reuptake by blocking dopamine transporter, right? Receptor, it blocks the vesicular reuptake by the vesicular monoamine transporter. So it blocks the vesicular reuptake. Okay, then some other examples are also there. Tiagabine, it is an antiepileptic drug. It inhibits the GABA transporter, right? So inhibits the GABA transporter, that is GAT1. Furosemide, it inhibits the sodium potassium 2 chloride co-transporter in ascending limb of loop of Henle, right? Or example है hydrochlorothiazide, they inhibit the sodium chloride symporter in early distal tubule. Then another very famous example, propanacid, it inhibits the organic acid transporter. So it inhibits the uric acid reabsorption and penicillin secretion. So these are the two drugs on which it acts. So this is the example of transporters and how the drugs exert their action through transporters. Okay, so we have seen enzymes, we have seen ion channels, and we have seen transporters. Now the next category, and that is the most important category, mechanism of drug action, that is receptors. So now let's move on to the receptors. Now before we move on to the receptors, you have to understand some definitions. First definition is affinity. and the second definition is intrinsic activity. So what is affinity? Affinity is the ability to combine. The affinity is the ability of the drug to combine with the receptor, and intrinsic activity is the ability to activate that receptor. Okay, so affinity and intrinsic activity. Affinity is the ability to combine with the receptor, and intrinsic activity is the ability to activate that receptor. Now the drugs are divided into agonist, right, antagonist, then we have partial agonist, and we have inverse agonist. Okay, so agonist, antagonist, partial agonist, inverse agonist. So in agonist, affinity is 1, intrinsic activity is 1. Antagonist, affinity is 1, intrinsic activity is 0. So it has no action of its own, right? Remember this. Partial agonist has affinity 1, but intrinsic activity is between 0 to 1. So they have a submaximal affinity, or sorry, submaximal intrinsic activity. And inverse agonist is affinity is there, but intrinsic activity is in the negative direction. So they exert action in the opposite direction. So this is specific of inverse agonist, and this is how we divide the drugs as agonist, antagonist, partial agonist, and inverse agonist. Right, now there is a thing called as log dose response curve, but before that let me explain you receptor occupation theory. Now receptor occupation theory says that it was basically there is a drug and there is a receptor. Now when they two combine, now this reaction can move in both the directions, and here K1 is the cofactor, here K2 is the cofactor, and together they form a complex which is called as drug plus receptor complex, which will produce the effect, right? Now depending upon this theory, so ability to combine with the receptor is the affinity, capacity to induce a functional change in the receptor is called as intrinsic activity, finally producing an effect. Now this agonist, antagonist, partial agonist, inverse agonist मैंने आपको बताया है कि किस तरीके से होते हैं, right? Now इसमें अगर हम इसी theory को लें तो it is said that in resting equilibrium the receptor is in two forms, active and inactive, and these two forms remain in a equilibrium with each other. Now when the agonist comes, so agonist के आते ही जो active receptor है वो और active हो जाता है, and it brings the response, right? And ये जो receptor है, ये RI जो है, it reduces, ये कम हो जाता है. This is when agonist comes. इसी जगह अगर यहाँ पे antagonist आ जाता है तो फिर ये थोड़ा सा active हो जाता है. Antagonist के आते ही inactive receptor will become more, and RA reduce हो जाएगा, active receptor will reduce, right? Partial agonist आके दोनों से combine करेगा, it will combine to this also, and it will combine to this also. So partial agonist will combine to both and will bring about a change in the equilibrium. Okay? Inverse agonist will combine to the inactive receptor, and इधर ये थोड़ा reduce हो जाएगा, and it will take the reaction in the opposite direction. Okay, so this is how the receptor occupation theory and the two-state receptor model इसको बोलते हैं two-state receptor model. In this, they are trying to explain how the receptors they function with the agonist and antagonist, right? Now the next thing that we cover is G protein coupled receptor. Okay, this receptor is very important to understand. It is also called as metabotropic, also called as serpentine or heptahelical. Okay, these are various names for the G protein coupled receptor. It is a 7 trans membrane spanning receptor. Now a specific part of this G protein is that it has got alpha, beta and gamma subunits. Normally in inactivated states they all remain together and they are attached with GDP and remain inactive, and whenever GTP replaces GDP then it becomes active, and for activation the alpha subunit separates. Okay, so that is what happens when there is change. Now there are different type of G proteins, that is GS, GQ and GI. GS causes activation, GI causes inhibition as the name itself suggests, and GQ basically causes modulation. Now both these they GS increases cyclic AMP and this decreases cyclic AMP, as in though both they act through the cyclic AMP pathway and activation of protein kinase A and decreased activity of protein kinase A. Modulation, GQ acts by activation of phospholipase C, which converts PIP2 to IP3 and DAG, and they further increase the calcium ion channels, right? So this is their main mechanism of action. Another mechanism is that they increase the permeability of ion channels, especially the calcium channels openers are there, calcium channel closers are there, and they also act on the potassium channels. So this is the activity by which the G protein coupled receptors act. Then the other category of receptors is called as ion channels. Okay, so how do these ion channels they act? These are the second type of receptors. These ion channels are basically pentameric structures. and they are also called as, they are like a rose petal, so they are called as rosette. A very specific feature about these channels is that they are fastest acting. We have nicotinic receptors, okay, then we have in the CNS we have GABA, that is an ion channel, and 5-HT3 receptor. All these are ion channels. They have an alpha subunit which attaches the drug, and then opens the channel, right? So this is the inotropic channel. The next receptor is enzyme linked receptor. Okay, now what is enzyme linked receptor? Enzyme linked receptor is basically present in the cell membranes, and it has got an intracellular and extracellular units are there, right? Now drug binds to the extracellular unit, and that causes dimerization of intracellular unit, and then further conformational changes, right? Now enzyme linked में दो तरीके के होते हैं. One is tyrosine kinase. Tyrosine kinase कौन सा compound act करता है? Insulin. And the other type is JAK-STAT kinase. The only difference is that in tyrosine kinase type of enzyme, the tyrosine kinase is attached to the beta subunit that is inside, while in JAK-STAT kinase, the JAK and STAT, they are free flowing. STAT is free flowing, it is not attached to the intracellular site. So JAK-STAT kinase से attach हमारे act करते हैं cytokines, growth hormone, prolactin, and interferons, right? So these. The fourth category of the receptors is intracellular receptors. They are also called as nuclear receptors, although they are cytoplasmic also, right? But ultimately दोनों की action मिलके nucleus पे ही जाती है, and there is a DNA change. So this is the fourth category of receptor, that is intracellular. ठीक है? Now cytoplasmic receptors से कौन act करता है? Corticosteroids. Nucleus से act करता है sex steroids. Then vitamin D. इधर जाता है vitamin A. उसके अलावा T3, T4, PPAR. ये सारे, these are the drugs, or these are the compounds that act through the intracellular receptor. These are cytoplasmic and these are nuclear receptors. This type of receptor is the slowest acting होता है, and only for drugs which are lipid soluble. ठीक है? So this is also important that they are active only for drugs which are lipid soluble. Now coming to the next part, that is regulation of receptor. Now these are just small concepts that you need to understand. Regulation of receptor दो तरीके के होते हैं. There is up regulation and there is down regulation, right? Now up regulation, when does it happen? When there is a prolonged absence of agonist, or there is a continuous use of antagonist. So when you use an antagonist for a long period of time, then the receptor will be upregulated, and this phenomena is responsible for clonidine withdrawal, opioid withdrawal, and propranolol in angina withdrawal, sudden withdrawal. Down regulation occurs when there is a continuous use of agonist, right? For example, levodopa in Parkinsonism. For example, beta-2 agonist in asthma, right? So this is the regulation of receptor. Now coming to a very important part of pharmacokinetics, that is dose response relationship. Okay, now dose response relationship is projected by two methods. One is a quantal and one is a graded. That is dose response curve here we are talking about. ठीक है? अब quantal basically क्या होता है? Quantal में basically they plot the dose here, and the dose is plotted here and the response is plotted here. Okay, now in a quantal DRC, actually what they are seeing is they are seeing the dose, and here they fix the population, okay, how many people, and then they calculate the, what are they calculating from the quantal DRC? Quantal DRC से calculate करते हैं ED50, LD50 and therapeutic index. Quantal DRC is used for drugs with all or none phenomena. ठीक है? Here in the graded DRC, it is done for use for drugs with graded response, and here there are two types. एक तो होता है dose versus response. तो या plasma concentration versus response. Dose को actually concentration से it is much easier. So this becomes a hyperbola. So hyperbola is in when you plot it with dose. So what they have done is they have calculated as per log dose response curve, and this is the response. So here the graph comes like this, which is sigmoid shape. Can you see? This is sigmoid shape curve, right? First, then this 30 to 70 is almost a straight line. 30% or 70% के बीच में it is almost a straight line, so it is very easy to calculate the it is easy to calculate कि कितने डोज पे कितना रिस्पॉन्स आ रहा है, सो क्वांटिफाई करना ईजी होता है, राइट. नाउ इसमें प्लस यू कैन लार्ज वेरिएशंस कैन बी प्लॉटेड, राइट. सो नाउ लेट अस सी ED50, LD50 एंड थेरेपेटिक वैल्यू. ये क्या होता है? व्हाट इज ED50? ED50 इज द डोज which brings a response in 50% people, and LD50 is the dose which brings which brings death in 50% people. And therapeutic index is a measure of safety, okay, and इसका formula है LD50 upon ED50. High therapeutic index drugs are safe, low therapeutic index drugs are toxic. ओके, थेरेपेटिक इंडेक्स हाई होगा मतलब LD50 ED50 से बहुत ज़्यादा है तो आपका थेरेपेटिक इंडेक्स हाई आएगा. अगर आपका LD50 और ED50 में ज़्यादा अंतर नहीं है तो आपका थेरेपेटिक इंडेक्स कम आएगा. दैट मीन्स द ड्रग इज नॉट सेफ. देयर आर चांसेस दैट इट विल हैव मोर टॉक्सिसिटी. देन अनदर थिंग यू शुड नो इज दैट इफ ED50 इज मोर then the drug is more potent, okay, and if LD50 is more then the drug is safe. So please remember this also. So this is the dose response curve, dose response relationship that we have talked about. Now what are the three important parameters? Let us see that. Three important parameters from DRC which we study in DRC. The first thing, suppose there are two drugs like this is A and this is B. So the first thing that we calculate is potency. Potency is determined by the position of the curve on the graph. A left one is more potent and as it goes right is less potent. Okay, so this is about potency. Then another thing is efficacy. Efficacy is represented by the height. Okay, so more height is more potent. So you'll get a lot of questions from this. The third thing that we get is slope of the curve. If it is steep, that means very increased response on increasing the dose. Only small increase in the dose will bring a major increase in the response. And if the curve is flat, it means very little response even after increasing the dose a lot. ठीक है, so these are the three things that we learn from the dose response curve. Now इधर ही मैं आपको बता देती हूँ कि कॉम्पिटिटिव इनहिबिशन की जब हम बात करेंगे, कॉम्पिटिटिव इनहिबिशन में सपोज ड्रग A is alone and then drug B is this. So here B is competitive antagonist. The curve shifts. Competitive antagonism में the DRC shift to right. Okay, remember this. And non-competitive inhibition, what happens in non-competitive inhibition? It will present like this, A, B. So here B is non-competitive. Why? DRC flattens. So if the graph is flattening down, then it is non-competitive. Got it? So these are very important things that you have to learn, remember from the DRC: potency, efficacy, slope, competitive inhibitors and non-competitive inhibitors. ये questions आते ही आते हैं, graph based questions आते हैं, इसमें आप mistake नहीं करो. Okay? So now we come to factors affecting drug action. Okay? So पहला point है यहाँ पे body weight. Body weight का formula क्या है? Body weight upon 70 into average adult dose. Okay, remember this formula. Second चीज, body surface area is more accurate basis for dose calculation. Okay, body surface area is more, and what is the formula? Body surface area upon 7 into average adult dose. ठीक है. Second factor होता है age. Age में जो pediatric group होता है, pediatric patients, now they are not small adults. ये चीज हमने पढ़ी भी है. They have a low GFR, they have reduced hepatic enzymes, and the half life gets prolonged in them. ठीक है, metabolism उनका slow होता है. So some examples that I'll write here, like chloramphenicol causes gray baby syndrome. Why does it cause gray baby syndrome? Because glucuronide conjugation is less. Then kernicterus is caused by sulfonamides. Okay, then half-life of theophylline, phenytoin and carbamazepine is shorter in children. Then children are highly susceptible to belladonna poisoning. That is the atropa belladonna poisoning, which is atropine. Okay. Then loperamide can cause paralytic ileus and megacolon. Okay, and this you all know aspirin causes Ray's syndrome, so not to be given in small children. Then the third factor which causes a difference is genetics. So इसमें मैंने आपको acetylation वाला एक point बताया था that there are some people who are fast acetylators, some are slow. And what are the drugs acetylated? Sulfonamides, hydralazine, then isoniazid and procainamide. So these are the drugs which are metabolized by acetylation. Then other genetic defects like atypical pseudocholinesterase. इससे क्या हो जाता है? Succinyl colon apnea. Then malignant hyperthermia. किसमें? Halothane. Then acute intermittent porphyria precipitated by barbiturates due to defect in the repression of porphyrin synthesis. So these are some genetically genetic जो बोल सकते हैं हम कि how pharmacogenetics यहाँ पे play होती है. Then we come to next concept, that is tolerance. Now tolerance occurs to drugs when they are used for a long time in a patient. So tolerance selective भी develop होती है. Like tolerance can develop to sedative effect of chlorpromazine, but not to the antipsychotic, right? Then tolerance can develop to sedative effect of phenobarbital, but not to antiepileptic effect. Okay. Then tolerance can develop to analgesic and euphoric effect of morphine, but not to the constipating effect. So इसके ऊपर भी ना कई बार क्वेश्चंस आते हैं, इसलिए मैंने आपको ये लिख के दिया है, मैंने आपको ये कंप्लीट किया है. मतलब आई नो इट इज़ वेरी बोरिंग, बट इस पे भी क्वेश्चंस आते हैं और फिर तब आपको लगता है यार थोड़ा सा पढ़ लेते हैं. और टॉलरेंस के ही साथ में एक और फंडामेंटल है टैकीफाइलैक्सिस. नाउ टैकीफाइलैक्सिस इज शोन बाय indirectly acting neurotransmitters, symptomatics like ephedrine, tyramine. They basically cause release of stored neurotransmitters, है ना. तो जब वो खत्म हो जाएंगे तो उनका इफेक्ट धीरे धीरे खत्म हो जाता है. तो टैकीफाइलैक्सिस वाला ग्राफ इट गोज लाइक दिस. नाउ there were some things related to prescription writing. So prescription writing mein if there are questions, they will ask you, they'll give you prescriptions for you to identify the errors. Like generic name में लिखना है, branded में नहीं लिखना है, capital में होने चाहिए नाम, there should be no abbreviations in the prescription. Okay, spelling mistakes avoid. तो ये सब चीज़ें प्रिस्क्रिप्शन में, प्रिस्क्रिप्शन राइटिंग के क्वेश्चंस में they can ask you. Okay, इसी के साथ 2-3 कॉन्सेप्ट और हैं. like what is this? Rational use of medicine. इसका कॉन्सेप्ट होता है राइट डोज, राइट ड्रग, राइट पेशेंट, राइट ड्यूरेशन, राइट dispensing. Okay, like this. Then there is something called as P drug. P drug is basically personal drug. Like every doctor has got their own a set of 45 to 50 P drugs. P drugs में सबसे important चीज जो देखनी होती है, they should be efficacious. तो efficacy, they should be safe, safety, tolerability, yeah, suitability and cost. So these are the 4 main criteria that you need to see with the P drug. And these are the things, if they ask you, you have to see that one of the options is there, right? Then some questions related to the expiry of drugs. अगर एक्सपायरी के बारे में बात कर रहे हैं तो इसमें आप समझो that quality of medicine not assured after expiry date. But ऐसा नहीं है कि अगर एक्सपायर है तो वो नुकसान करेगी, it will become toxic. No. Okay, so this is one point about expiry of the trait. Then economics. इसमें एनालिसिस होते हैं, कॉस्ट बेनिफिट एनालिसिस होता है, कॉस्ट इफेक्टिव एनालिसिस होता है, कॉस्ट यूटिलिटी एनालिसिस होता है एंड कॉस्ट मिनिमाइजेशन एनालिसिस. ठीक है, ये फार्माकोइकोनॉमिक्स के ये एनालिसिस होते हैं. सो दिस यू शुड कीप इन माइंड. नाउ द नेक्स्ट वेरी इंपॉर्टेंट, नाउ डेज दे आर आस्किंग क्वेश्चंस ऑन दिस ऑल्सो, दैट इज क्लिनिकल ट्रायल्स. क्लिनिकल ट्रायल्स के ऊपर आजकल बड़े सारे क्वेश्चन पूछते हैं, तो इसको देख लेते हैं अच्छे से. क्लिनिकल ट्रायल्स अमेरिका में FDA अप्रूव करता है, हमारे यहाँ पे DCGI इज द अथॉरिटी, ड्रग कंट्रोलर जनरल ऑफ इंडिया. नाउ सबसे पहले ड्रग होती है IND, दैट इज इन्वेस्टिगेशनल न्यू ड्रग. ओके, नाउ दिस IND फर्स्ट ऑफ ऑल इट गोज इन phase 1. नाउ phase 1 is a mainly safety study. It is done to calculate the maximum tolerable dose. It is done in healthy volunteers. Efficacy is not tested in this, and it is done in around 20 to 100 healthy volunteers. Okay, so this is phase 1. phase 1 के बाद ड्रग आती है phase 2 में. phase 2 is mainly efficacy study. इसमें सिंगल ब्लाइंड स्टडीज होती हैं, इसमें 100 to 150 पेशेंट्स होते हैं, and this is first time efficacy study. Okay, and they're single time. After that we have phase 3 trials. Phase 3 trials are double blind trials. They can be randomized controlled trials. Okay, they are done in around 5,000 patients at multiple center. So this is a multi-centric study. Now after phase 3, if everything becomes well, then it is launched in the market as a new drug. Now once it is launched in the market, then we have phase 4, which is called as post-marketing surveillance. And post-marketing surveillance में basically we confirm the efficacy and long-term toxicity. ये भी देखा जाता है, ठीक है? So this is phase 4 trial, which is finally then the drug is there in the market. So clinical trials में ये पूरा system है, आपको पूरा अच्छे से आना चाहिए. Investigational new drug phase 1, phase 2, phase 3, number of patients, maximum tolerable dose वहाँ निकालते हैं. अच्छा, एक होती है phase 0. Phase 0 क्या होती है? Microdosing study, in which very less number of patients, healthy volunteers, and उनके ऊपर dose देकर फार्माकोकाइनेटिक स्टडी करी जाती है. बेसिकली क्या है ये? फार्माकोकाइनेटिक स्टडी, ठीक है? So this is a pharmacokinetic study. Phase 0 is a microdosing study. Very less number of people, healthy volunteers are taken, right? Forgot to click the camera. So the last part of general pharmacology is adverse drug reactions. In this is the program Pharmacovigilance, which is called as Science of Detection, Understanding, Assessment and Prevention of Adverse Effects. It is under CDSCO since July 2010. The National Coordinating Center was AIMS, New Delhi, and now under it IPC, that is Indian Pharmacopoeia Commission in Ghaziabad, is the PBPI center. All medical colleges are now ADR monitoring centers. They play a pivotal role in PBPI. The software which is used at the level of NCC is Vigiflow, at the level of WHO and UMC is Vigibase. WHO का Uppsala monitoring center which is there in Sweden. Okay, यहाँ पे Vigibase. The scale for causality assessment is the Naranjo probability scale, Naranjo assessment scale. What are the types of ADRs? Type A is augmented. Okay. Type B is desire. Type C is chronic. Type D is delayed. Type E is end of dose. Okay, so these are the different types of adverse drug reactions. In causality assessment, any assessment is said as certain when there is a temporal relationship, that means a time bound relationship, when there is a pharmacological explanation for that particular adverse reaction with the drug, when there is de-challenge, and then when there is re-challenge, right? So this is something important that you should know when we are talking about the adverse drug reactions. बाकी तो देखो adverse drug reactions किस दवाई से क्या होता है ये तो अपन systemic pharmacology में भी पढ़ेंगे ही साथ के साथ. ओके, एक इंपॉर्टेंट चीज जो यहाँ पे मैं आपको साथ के साथ बताना चाहूंगी, दैट एलर्जिक रिएक्शंस हो गए, एनाफिलेक्टिक शॉक हो गया, उसमें एड्रेनालिन इज गिवन बाय IM इंजेक्शन 0.5 मिलीग्राम, दैट मीन्स 0.5 ml ऑफ 1 in 1000 solution in adults. Please remember this dose. You should not make a mistake. It is 1 in 1000 solution given by IM route. IV route not given because it is toxic. Apart from that, we give antihistaminics, okay, and we give IV glucocorticoids also. So this is something very important. Now the last part, just a few things, important things that are usually asked and we should complete them. First is gastric lavage. जैसे poisoning वगैरह होती है तो gastric lavage is contraindicated in corrosive acid poisoning and in kerosene. Kerosene क्या होता है? Volatile होता है, तो वो उड़ के respiratory उसमें चला जाएगा and then it will cause difficulty in breathing. Second, forced alkaline diuresis is done in poisoning of acidic drugs like phenobarbital. This I have explained also inside. Third, schedule H की drugs prescription only होती हैं. I have explained the schedules and the categories for pregnancy also. Antagonism में मैंने आपको बताया भी है शायद कि एक होता है physiological antagonism, जबकि मतलब उनकी actions एक दूसरे के against होती हैं. So adrenaline is a physiological antagonist of histamine. Okay, इसीलिए एनाफिलेक्टिक शॉक में एड्रेनालिन दिया जाता है. एंड देन अदर एंटागोनिजम्स आर फार्माकोलॉजिकल. सो फार्माकोलॉजिकल एंटागोनिज्म जैसे एड्रेनालिन का एंटागोनिस्ट है प्रोपेनोलोल. ओके, सो दीज आर सम मोर इंपॉर्टेंट थिंग्स व्हिच आई फेल्ट कि एक बार को हम थोड़ा सा रिवाइज भी कर लेते हैं. सो विद दिस नाउ दिस वी फिनिश जनरल फार्मा रैपिड रिविजन RR series general pharma, and next tomorrow we'll take the ANS. Okay.